All right, thank you. We're going to move on to our next talk. Thank you, Dr. Entwistle, for that. Our next speaker is going to be Dr. Chris Karras. He is my partner at Ohio Health Grant Medical Center. He's a neurosurgeon and is also the chair of the Division of Neurosurgery, so he's my boss. And he's fellowship trained in endovascular neurosurgery, and he's done 2 trips to Kenya. One of his trips was to Kijabe, and then he also did a trip with me to Kisumu. So it's a pleasure to have Dr. Karras here. He's also the co-director of this symposium. Thank you. Welcome, Dr. Karras.
Thank you, Victor. My first trip to Kijabe, I did not see Leland Albright, who you had mentioned earlier, but the person who I think was overseeing a lot of what was happening in surgery there was a man named Dick Bransford. He is very old, very retired. He is recently very ill, and so it's somebody we've been thinking about lately. He really built the program there in an amazing way, and from the limited time I was there, what I saw was pretty impressive, and it looks like Kisumu was heading in the same direction. So today, I'll be talking about surgical and non-operative options for degenerative spine. As surgeons, we often don't want to talk about the non-operative options. But it's something that we have to often discuss with our patients, since in our practice anyways, the majority of our patients that we see in clinic are non-operative, and they want to know what options are there. As you know, in spine surgery, especially degenerative spine surgery, there are so many things that we can offer. So what does it even mean many times to be operative or non-operative? I would say that in the majority of degenerative spine patients, what we're operating for is pain. And typically, once they get to the point of surgery, it's because other pain management options haven't helped. And what are those options? The non-operative options typically are medications, injections, and physical therapy. And there are many permutations of that. But if a patient fails medications, injections, say epidural injections, rhizotomies, facet injections, medial branch blocks, if they fail these, what we consider non-operative options, then we have the option for surgery. Surgery, we have found over the years, doesn't always treat pain, or sometimes you can trade one pain for another. And so we have this syndrome of failed back syndrome, and that can be lumbar, thoracic, or cervical. And so in this talk in particular, I'm going to talk about spinal cord stimulation as a bridge between the non-operative and operative options, especially for pain. If we're talking about a patient with a foot drop, motor deficits, myelopathy, these things are typically surgical. A decompression has to be done. Fusion may have to be added if we decompress in a way that destabilizes. But in a patient with pain, the options for surgery are still decompression and fusion, depending on what we feel the generator of the pain is, or continued pain management. Pain management is often temporary, the non-operative options, and stimulation we consider more a permanent method of pain management in somebody who we know will have lifelong pain issues with their back. And so in the first couple slides here, I'm going to show a few different pathologies that we've all seen and we've all approached in different ways. And I want you to think, as you look at these, how would you treat this? This first one is a patient with a previous fusion from L3 to S1. And then at the level above, there's clearly some adjacent segment degeneration and stenosis. How would you treat this? Decompression alone, decompression, fixation, fusion, or in my practice, the third surgical option is stimulation. Is that an option? We have these other ones, previous fixation fusion on the left. In the center, no previous surgery, some disc herniation, some small grade 1 retrolisthesis at L5-S1. Small changes that we've all seen, spondylosis essentially, without significant canal stenosis. And then on the right, maybe more severe canal stenosis, obvious foraminal stenosis. But all these patients, I will continue to remind you, only have pain. They don't have bowel bladder dysfunction, so no red flags on exam and no red flags radiographically. We have a patient that's presented with pain. And I'll take it one step further. All these patients, we get flexion extension films regularly, x-rays. They are all stable on flexion extension. So radiographically stable, radiographically no red flags such as signal change in the cord, and clinically no red flags, no bowel-bladder dysfunction, no weakness. Here's another set. You look at the middle one, we see just pseudoarthrosis from a previous ACDF, but the hardware seems to be intact. Spine remains in a reasonable alignment. How would we treat this patient's pain? Surgically, we have the options of revision fusion, for instance, and then these other images that show, like I say, very typical things that we see in spine surgery pre and post-operatively. The question ultimately is, how will we treat their pain? And so if we send them for non-surgical pain management, typically we send to a medical spine or interventional pain management partner who will decide on therapies, injections, medications, and manage the patient's pain, but maybe not cure it over time. In some patients, we'll go the surgery route and start to discuss fusion, decompression, or stimulation. So today I want to talk about that stimulation portion of the operative algorithm, because it's not something that neurosurgeons often do. It's a practice that is limited in spine care in general. If it is addressed, if any pathology is addressed with stimulation, typically it's by a pain management physician first. I began to do spinal cord stimulation. I learned it some in residency, but began to do it in my clinical practice when pain management physicians who would place a trial of a stimulator just through an epidural injection, place a trial of a stimulator, found good results, they would send the patient to me for a permanent implantation. And so I had to learn the ins and outs of stimulation for that reason. And now over a decade of doing this, I've discovered that it is something that neurosurgeons should discuss with patients as an option. It is, I consider it to be a surgical option. Generally, in the United States anyways, a lot of what we see in pain management for the spine comes to the neurosurgeon. So all this is funneled. Degenerative disease, spondylosis, back pain, leg pain, radiculopathies are funneled to the neurosurgeon first. And then we have to decide where we send them. If I see somebody without any surgical issue at all, obviously they go to pain management. But all those previous images that I showed, every one of them had a surgical issue. We could always revise instrumentation. We can do an adjacent segment decompression and fusion. We can do decompressions. We can do a pseudoarthrosis revision. So they are all surgical. But as you know and I know, we often send these patients to pain management first anyways. And so part of the surgical algorithm is that they have failed conservative measures. They have failed interventional pain management and medications. And then we can decide to do surgery. So in my practice, we'll see these patients, let them know what surgeries are available to them when they're ready. But I usually encourage them to try pain management first. And if that fails, surgery is an option. So like I say, most of the patients we see are non-operative. So this conversation is our most common conversation in the clinic. But if I see these, what I consider typically non-operative patients, patients that don't have, patients that have a stenosis, something that we can decompress, maybe a slight but stable listhesis that we can reduce, open the foramen. While they're surgical, while we can talk to them about treating the root of the problem, which is the stenosis or nerve impingement, we can also discuss with them stimulation without changing the spine, without decompressing or fusing any portions of the spine. And so this is an interesting conversation with patients because some of them want what they consider the root of the problem to be treated. Take the pressure off and let's see if this nerve heals. Others say, I want to avoid any large surgeries, and so they're willing to try interventional pain management, which would include stimulation. So what happens is the majority of the patients I see in clinic who were previously non-operative are now operative within the stimulation algorithm. This is just a representation of an algorithm of somebody who does both stimulation as part of their practice and who doesn't. And so you can refer to pain management to get the process started, or this is something you can take care of on your own. So who's a candidate? Like I say, anybody who you think is a surgical candidate under a normal algorithm for decompression or fusion is typically also a candidate for stimulation. And that's the most important point, that stimulation is a small, outpatient, predictable, easy to recover from procedure that you can offer for a patient who is also a candidate for decompression or fusion, provided that patient doesn't have any red flags on exam. They're not weak, no bowel bladder dysfunction. It's purely a pain clinical syndrome. And so this technology has been approved by our FDA for failed back syndrome, for radicular pain, secondary to stenosis, herniated disc, for any spondylitic issues that are causing pain in a patient who either doesn't want surgery or is not a good candidate for a fusion surgery, maybe poor bone quality, and you're seeing a lot of opportunity for fixation failure. There's also off-label uses, which we do quite often, and in fact, in that list, I have to change that over. Diabetic neuropathy is now in the FDA-approved utilization. And so a large portion of patients with diabetic or other chronic neuropathies, including chemotherapy-related neuropathies, are candidates for stimulation as well. So what's the conversation I have with the patient in clinic? Assuming I see somebody, for instance, with a lumbar stenosis that's moderate, and then multi-level of the canal, and multi-level foraminal stenosis, who's 75 years old and osteoporotic, has a heart condition, and is looking for options now because medications, injections, and therapies have failed. And it's really, this pain is what's causing their functional disability. It's not a functional disability related to weakness. Well, in that patient, stimulation is an excellent option. We know this pain will be there for good. We know the degenerative process isn't going to reverse itself. And so we need something that can be more permanent as a solution to the pain rather than temporary injections or medications. So if we talk about fusion in this patient, the patient needs to know the fusion changes your anatomy, and sometimes that can cause a different type of pain. A fusion is essentially irreversible. Fixation is not, of course. You can remove the instrumentation, but fusion is generally irreversible. And the results of fusion are less predictable. I will tell patients I can fuse your spine, I can decompress it, we can make the MRI and x-rays look much better. But it is hard for me to say whether you will feel better or not, especially in patients with chronic neural impingements. This nerve may be permanently injured, and even decompression won't help it. On the other hand, stimulation is something which preserves the native spine. It's reversible. The stimulator, once put in, comes out very easily. All implantations, trials, revisions of stimulators are 30 to 45-minute procedures, which are outpatient. And it's predictable. Every stimulator patient requires a trial, which is simply an epidural injection, but instead of injecting medications, you add the wire into the thoracic epidural space. That wire is external for several days while the patient tests the function of it. And if they have greater than 50% pain relief, we can put in the permanent implant. And so it's predictable because you can have a trial, unlike the fusion. It's reversible, unlike the fusion. And it does preserve your native spine, which avoids the complications of changing someone's native spine through decompression or fusion. And again, trading maybe one pain for another. The question I have as a surgeon that performs spinal cord stimulation is, do I send for a trial or do I do my own trial? There are now some subtle differences that go into the decision making for stimulation. If I do a trial or if I have a partner that does trials for me in pain management, I request that they do an x-ray when they place the trial so I know exactly what level they place the stimulator electrode. I ask that they do an x-ray the day they pull the trial back out. So in the office, 5 or 7 days later, the trial is removed. If we have x-rays both of those days, and I know which day the patient had the best stimulation, then I'll know the best target because these stimulators may move during the trial. And then from the stimulator programmer, I need to know what their best program was. With that information, we can then place the stimulator where the trial was placed and get the best outcome. And so in the neurosurgery world, often we have just been the person to implant the stimulator. But if you're doing trials or you're aware of what's happening in the trial and permanent implant results should be very similar. And that helps us to have the best outcome in the long run for the patient. So that's how stimulation works. First, we place a trial for 5 to 7 days, just a needle procedure that takes 15 minutes, and they go home with this and test it. Later, they come back for a permanent implantation if the trial is successful. And the permanent implantation requires 2 incisions. Now, this is a 30 to 45-minute procedure under fluoroscopy, where we place the leads in the same position as the trial through needles. Then we place the leads under the skin in a midline thoracic incision. So that's a subcutaneous dissection only. And then a second incision is made horizontally, either in the right or left flank, according to the patient's preferences, to place the battery. And with a shunt passer, we pass the leads from one incision to the other, connect it to the battery, and both are implanted subcutaneously. Because it's a subcutaneous dissection only, the postoperative pain management is rather simple. Also, the stimulator is turned on the day of surgery in my practice, and so those patients go home with the same pain control they had in the trial. And so there's a significant amount of pain relief the day of surgery rather than additional pain. When we place, actually I should go back one, when we place these, if somebody has a trial with percutaneous, there's many styles of leads that you can place with stimulators, and there's many different companies. But we recommend that you use the same company and the same style lead for the trial and permanent to get the best outcome. Patients will know how they felt in the trial, and they will want the same result in the permanent. And if we change the company, the style of programming, if we change the level that we place it, or the style of leads, we can have a different outcome with the permanent placement. And that often is the biggest pitfall of stimulation surgery. And so having a trial and permanent that match up with respect to hardware and location is extremely important. There are some complex situations. There are patients with previous laminectomies, and so it's hard to thread these leads. There's patients with previous fusions. And that's why I believe that this should be something that's done more under the neurosurgical specialty than under the pain management specialty. Pain management physicians are capable of placing percutaneous leads in certain patients. Neurosurgeons are capable of placing all types of leads in all locations, even where there's previous laminectomy or fusion. In addition, if a patient has an issue with their stimulator, the neurosurgeon is most capable of removing the stimulator, removing parts that may be retained if a foraminotomy or laminotomy is necessary. And so it is one of the procedures that I feel has a great impact on spine patients, but it should be under the auspices of neurosurgery in general. And so the hope is to spread this to more neurosurgeons rather than have it be something that's typically under pain management or interventional pain management. All the manufacturers, Nuvectra now has gone bankrupt. That's actually off the list. But all the manufacturers that are here and the ones that are coming, there are more coming, are all doing, in leaps and bounds over the last 5 and 10 years, are making significant improvements in technology. And so these generally all are now MRI compatible, which has made care of the spine after stimulation much easier. The batteries are guaranteed for 9.5 to 10 years. There are rechargeable and non-rechargeable forms. The rechargeable batteries, the patient just sits on a pad and charges it every few days. There are also new companies that are not yet FDA approved, but they are in production that are creating stimulators for motor improvement rather than just sensory and pain improvements. And these have been trialed in patients with complete paralysis for 2 years. So it was considered to be a complete lesion that is ongoing. And in all the patients that they've trialed it in with 2 separate companies, they have found that the patient can walk, swim, or stand with this stimulation. I have talked to those companies and their engineers, and it sounds like FDA approval for those stimulators are coming in the next 3 to 4 years, actually. And so you will start seeing this for paralysis as well. In which case, I do believe, because neurosurgeons are the ones managing patients with paralysis, with spinal cord injury initially, the discussion, at least, of stimulation should be had for pain control here in the short run, and in the long run, even motor improvements after paralysis. There are complications that go along with this, like with any foreign bodies that we implant. You can have infection. The algorithm is simple. You remove infected ones. You remove ones that are failed. If the patient doesn't like it anymore, there's a new issue. I tend to leave them in, though, if a patient's having a new lumbar surgery anterior or posteriorly, because it does help with postoperative pain control. There are compensation considerations which apply in the U.S., but the bottom line is percutaneous leads are a 10-day global period, and it's 90-day for paddles. All the compensation has increased over the last 5 years or so. And so a discectomy, for instance, single level would be 13 RVUs. For a stimulator, it's about 17. Just to give you an idea of how Medicare and Medicaid approach these. So at the end of the day, stimulation, I do still consider conservative management, but it's conservative management that surgeons can apply. It can be done with great long-term results, which is the goal. And it is something which I feel like should be under the auspices of neurosurgery. And that's why I showed these images here. The image on the right is a schwannoma, which can be treated surgically or with radiation, with radiosurgery. Neurosurgery has begun to take over its role in radiosurgery, in endovascular surgery, and we should have kind of the same approach to stimulation with regards to pain management. And with that, I'll let anybody ask questions. Thank you.
Thank you, Dr. Karras. So any of the faculty have any questions for Dr. Karras? Anybody?
All right, very good. We can move on to the next.
No,
go ahead.
This is David Okochuli.
Yeah.
I just have a comment. Sorry, my video's gone off. Yeah, the approach to your pain management. We actually have an arrangement of getting this carried out at the Aga Khan University Hospital. There are 2 neurosurgeons, Mahmoud Qureshi and myself, and with a pain management specialist, Dr. Tikra Sharif, who have actually been doing this. We had initial support by trade. The instruments that we use are Medtronic. We have got our nurses trained with that. So there are people who have these devices in and has made a difference. For the last year or so, there's been a challenge with getting the equipment in. But and the cost-wise, we've tried our best to minimize it. I think when you look at the procedure, the implant, it works out to be about I think it's about 15,000 US. That's from the moment you put in the first implant and the trial, and then the final one plus the battery is about 15,000 US. And if you look at how people have been suffering with pain, at least it's available within our site. So that is actually available within Kenya. Thank you.
That's good to hear. In America, it's about 20,000 for the equipment, but the long-term costs are smaller than they would be, say, after a fusion surgery. And so those costs have to be weighed. But the upfront cost is high for stimulation.
Thank you, Dr. Karras.